Okay, welcome everybody. So glad you could join us here today. My name is Joe Gogler. I'm one of the directors of the State Alzheimer's Research Support Center. We're really thrilled that you are with us here for our most recent Learning Collaborative meeting, actually featuring the Minnesota EHR Consortium and Dr. Tyler Winkelman. I think you're going to find some really interesting insights of some of the great work that Dr. Winkelman has been doing around EHRs and with potential for dementia care services as well. Next slide, please. So a real quick disclaimer, again, the STARS Learning Collaborative and the STARS Center is funded by the National Institute on Aging of the National Institutes of Health. Content here that we're going to be presenting is the responsibility of us as presenters and does not represent the official views of the National Institutes of Health. Next slide, please. Real quick overview of what the STAR Center is. Our goal is really to facilitate state-based research on dementia care coordination, integration, and transitions, with really one of the goals to create within as well as cross-state data infrastructure and resources to facilitate our understanding of what types of dementia care innovations work and for whom within and across said states. Our center also operates to disseminate findings and share best practices and learnings. Certainly the Learning Collaborative is one element of that. Really encourage you to check out our website at starcenter.org. You can see there more information on resources that we've been compiling. This includes some very exciting funding opportunities. Some of you, if you don't know about, might be interested in pursuing. We have our next cycle of, for example, dementia care innovation grants coming up this spring, and you or your colleagues might be interested in pursuing that. So again, feel free to visit us at starcenter.org. There's a QR code there for you as well. Next slide, please. So really quick questions will be addressed at the end of the webinar. To do so, to ask questions of Dr. Winkelman, please use the Q&A box in Zoom. You can also send us any follow-up questions or comments that you might have at starcenter@umn.edu. We will be sending out a brief survey at the end of this seminar. Please do take a chance to complete that. It's very helpful for us, not only to judge and ascertain the quality of our offerings, but also to help us identify other topics in the future you might be interested in this space of how do we best leverage existing data or new data to advance our understanding of what works in terms of dementia care services and supports in our communities, states, and beyond. Another key point here, this question is often asked, we will record this webinar and it will be available again at starcenter.org. So if you'd like to share this, if you'd like to revisit any of the exciting content, please feel free again to visit the website. Next slide, please. So really excited to have with us Dr. Tyler Winkelman. He's the Division Director of General Internal Medicine at Hennepin Healthcare here in Minneapolis. He's also Director of Research and the Evaluation Data Analytics Core of the HHRI, the Hennepin Healthcare Research Institute. He's also an associate professor with us here in the med school at the University of Minnesota. So Dr. Winkelman, thank you so much, and I'm going to turn it over to you.
Thanks, Joe, and thanks all for attending. I am going to share my slides, and I will also keep an eye on the chat and happy to answer questions that folks might have as we go. So let me just get my chat set up here quick. All right. So I'm going to be talking about a collaboration that I've been a part of since its inception in 2020 called the Minnesota EHR Consortium. And I've had the opportunity to be involved and lead a number of projects through this group, but this really is the work of dozens of folks across Minnesota. And this really is a reflection of all the hard work that our group has done. So I am the messenger, but by no means have been the only person working on this. I'm going to talk about just a little bit of how the consortium formed and why. I'll review some of the nuts and bolts of how the model functions. I'm going to give a couple examples of projects that we have run and their relevance for the care of older adults, and then talk about some things that we are working on in 2026, and then have concluding remarks. So I start almost every talk I give about the consortium with this slide. There has been a lot of talk over the years about bringing together the siloed systems of public health and healthcare. I love this figure on the right, which comes from the American Academy of Family Practice, and really highlights how much overlap there is in the disciplines of primary care and public health. And we in the US have had relatively siloed public health and healthcare sectors. But for folks who are truly interested in improving the health of the population, we have to find a way to bring these sectors closer together with a population health focus. And so in that context, a group of us across those sectors in Minnesota really saw a way for electronic health record data derived through the traditional healthcare system to fill gaps in public health reporting and to foster collaboration between these sectors. Electronic health record data offers a few advantages compared to more traditional public health data. Not to say that traditional public health surveys aren't useful. EHR data just have different functions and some advantages depending on the use case. For one, EHR data is timely, so we're getting real-time updates as soon as they're entered in the electronic health record. You can identify granular geographies and demographic characteristics. Typically, a patient's address is available to be geocoded within the electronic health record. And these are established collection methods that are happening in clinics and hospitals across Minnesota. And there are opportunities to link this data with administrative data, which I'll talk about in a bit. The other piece that our collaboration has really thought about and was central to how we designed the network was the observation that centralized approaches to data collection and data storage have often failed or been slow in the US. And a nice thing about EHR data is that they can be aggregated without a centralized data source. And I'll show you how we do that in the consortium. And then we saw that by using electronic health record data, there was really a unique opportunity to bring public health and healthcare closer together to both meet analytic needs and data needs, to identify at the time multiple pressing crises. This came out of the COVID era, and we have found that sort of the methods we developed to address COVID have been useful in addressing and identifying the myriad public health crises that we face in Minnesota and across the US. So over the first, I guess, 6 to 8 months, we brought together the 11 largest health systems in Minnesota, the Minnesota Department of Public Health, and county public health agencies. And our mission is to improve health by informing policy and practice through data-driven collaboration among members of Minnesota's healthcare community. There are a few key principles that drive this collaboration. One is that we are intentional about creating linkages and collaboration opportunities between healthcare systems, public health at the state and local level, and other sectors such as housing. Participation in our projects is voluntary. Sites can choose which projects they want to participate in. We focus on good governance. Through our governance board, we have an executive committee that meets more regularly. We have a scientific review committee and other cores. We have prioritized privacy through a distributed data model where we're able to bring together statewide insights without needing a centralized data repository. We really focus on making strategic decisions that maintain the adaptability and nimbleness of the consortium to address current crises and provide timely data. And we are governed by a master data use agreements that facilitates deduplication and sharing of granular summary data across each of the participating sites. The master data use agreement is a template that we were able to get agreement on across all 11 sites. And so as folks think about potentially collaborating in a similar network, would be happy to share that agreement with folks who are interested. This is the rough structure of how the consortium is formed. We have a governance board with a number of committees reporting to the governance board. The board is made up of a lead from each of the participating sites, as well as key state agencies involved in the work. And then we have an executive committee that includes our technical assistance core and administrative core, and meets regularly to queue up items and follow through on actions of the governance board. In terms of coverage, like I mentioned, we cover the 11 largest health systems in Minnesota. Many of those systems cover border areas, and so we do extend into the Dakotas and Wisconsin. And we capture about 94% of people who live in Minnesota. This is a recent graphic that we put together for a paper that's currently under review, comparing the denominators from the Minnesota EHR Consortium to denominators in the census. There are some counties where we have a higher number of patients than what the census reports lives in a given county, and slightly lower in other counties. Our lowest counties have about 40% coverage, 40 to 50% coverage. And so when you compare that to sort of the coverage of a given population survey, the total N is generally dramatically higher. But certainly we do have a couple places where we're trying to add the local community clinics in those spaces to round out the comprehensiveness of the coverage in Minnesota. But for most counties, coverage is quite good. When you deduplicate our estimates and you look at the total number of patients in the consortium, we report on about 5.6 million people, which is very close to the census estimates. This is from our dashboard. We're currently undergoing a server change. So it's very possible it may not be up right at this very moment. It's mnehrconsortium.org. And if it's not up right now, it should be up later in the day or tomorrow. But should be more responsive and working better on our new servers later in the week. And this is a publicly available dashboard that I'm going to talk more in depth about. But the key point here is that we cover the vast majority of Minnesota through this model. You can see the age distribution here. And for this group, I wanted to highlight, so these are our 2024 estimates. You can see this the sort of baby boomer group here. And you can see going back just 4 years ago, this population starting to move through the distribution here. So in sort of real time, you can start to see through the dashboard these different age cohorts move along the x-axis, and we're able to monitor health trends in these populations. So how does this all work? We have a number of data sources. As our name implies, we have access to electronic health record data at each of the systems. We are doing work to increase the social determinant of health screening data that is available. So as systems are mandated to collect SDOH data, we're using standards that have been supported through the Gravity project and mapping those standards to our OMOP databases. We also receive administrative data from a number of statewide agencies, including the Homeless Management Information System, HMIS, Department of Corrections. We receive mortality data from the state and have received vaccination data on COVID and flu vaccines, as well as Medicaid enrollment data. We incorporate climate data as well, and have a project that is focusing on emergency department use around extreme climate events such as heat waves and poor air quality. And then we also link this data with area level census data, including sort of average median income, the rurality of a given census tract or zip code, and the social vulnerability index that's produced by CDC. These are the demographics of a couple of the vulnerable populations that we pull in through statewide data sources. And you can see here the sex and age distribution for folks in the data set who have recently been enrolled in Medicaid, recently incarcerated, or recently homeless. We chose to build our database at each of the sites on the Observational Medical Outcomes Partnership Common Data Model. There are a few reasons why we chose this as the model for the network. One, it's an open source common data model that is internationally used. It is the common data model of choice for many large NIH studies, but there are hundreds of universities across the world that now use this model. We had some experience in Minnesota at a couple of the sites using this model, and increasingly sites joining networks that required this model to participate. We also made a very intentional effort to build capacity within each of the health systems. And what I mean by that is, rather than have one group who could build the model at each of the systems, we funded analysts within each of the systems to build their model and to really understand in detail how this model works, and what the mappings look like, and how to do quality assurance. And that has been absolutely critical. No matter how standardized these common data models are, there are always site-specific nuances, and having a champion, an analyst champion at each of the sites that really understands how the model works and how the specific mappings at that site work is critical when you run quality assurance for a given project. So for those familiar with the common data model, OMOP is not particularly unique. There are a set of tables that you map the items from your particular electronic health record into. There's a very robust online community that's built a variety of free tools to help in the mapping process. And each of the sites in Minnesota has chosen to follow the same procedures in mapping. So there are some decisions that need to get made as to specifically how you map over your data from your electronic health record into the common data model, and doing that together ensures that you're comparing apples to apples. For those less familiar with the common data model, essentially you can think of it as a language. The language of OMOP is concept IDs. So essentially, no matter what electronic health record you're using, you translate that data into these concept IDs so that each partner in the network is speaking the same language, so that when you pull data from one site, you know that you're pulling similar and comparable data from another site. Right now, OMOP at each of the sites refreshes at least monthly. We standardize this across each of the systems so that we update on the same day every month. We are working towards incremental refreshes where daily the newest data is being refreshed into the database. A number of sites have already moved in this direction. And then in addition to these updates to just get the data mapped over, we are continuously doing data quality checks to ensure that the data that should be in the database is there. We have a process where we match in administrative data and deduplicate records across the health systems. About 75% of patients in Minnesota have a record in more than one health system, and 32% have records in 4 or more health systems. So deduplication is really important when you're trying to create population level estimates. We use secure one-way hashes to link records. So folks may have heard this PPRL, privacy preserving record linkage. This is how we link in external data sets to the electronic health record data. And it's an algorithm that is based off of first name, last name, date of birth, sex, and then occasionally we'll use phone number and zip code. There are demographic characteristics and healthcare utilization data that we use to attribute a patient to a given system. So when we deduplicate, we need to assign one site to do the reporting, and we use this information to say we think this system's most likely to have the bulk of a given patient's information. And so we've tried a number of different algorithms to assign patients, and have found that prioritizing based on where the most demographic characteristics exist tends to have the most medical information as well. So this is a high-level schematic of how the network works. You have a researcher or evaluator that has a clinical question. You need to define how you're going to characterize your variables of interest. Then each of the sites is sending their hash IDs to our central data coordinating center that's run by the Hennepin Healthcare Research Institute and the University of Minnesota. And this privacy preserving record linkage then allows us to deduplicate. We enrich the data with administrative data, and we send back the hash IDs with the attached administrative data to each of the sites. They're also sending, information and metadata that we can use for quality assessment. The analysis will get sent to each of the sites once they have their deduplicated file with the administrative data. They then run the query and send it back to the coordinating site that aggregates the results and creates a statewide estimate. So the researcher is not necessarily responsible for the record linkage or the quality assessment, but they do need to work with the coordinating site to ensure that sort of the data that's needed are harmonized and defined appropriately. And then the bulk of the work for a given researcher is working either within their team or with their analysts to make sure that the R code is generating the results that are desired for the given study. But once the R code is written, it's been QA'd, running that at another site is relatively straightforward. So that is a fair amount of technical information. So what do these queries and data methods result in? So our most expansive project to date has been what we call Health Trends Across Communities in Minnesota. This has been a true collaboration between healthcare and public health. And the goal of the project was to produce actionable, disaggregated, open access data on our website intended to support public health organizations and healthcare systems in informing their community health needs assessments and community health assessments. These public health organizations often either have very delayed or very limited information on the health conditions in their specific geographies. And so organizing data across health systems provides much more meaningful population level health estimates. It also helps jurisdictions monitor health trends in real time and in between periods when they are needing to do their health needs assessments. It is possible to evaluate population interventions and has been used to inform local budgets for the coming year as different health priorities have been identified. And then as part of Health Trends Across Communities, we've been spinning off a group we call the Implementation Core, which is using the data that's been aggregated and filtering it to operational folks within the health systems who collaborate to make progress on key clinical outcomes like hypertension management or pediatric vaccinations. On the right here is an example of one of the maps that we produced that maps dementia across the state. And this would be, I think this is not age limited, which is why the prevalence looks low. But in terms of the health conditions that we report in HTAC, we report on a variety of substance use conditions, mental health conditions, chronic conditions, maternal and child health conditions, and then we report on combinations of these conditions as well. So here's an example of our prevalence page. This is prevalence of dementia across the age spectrum for individuals 60 and older. On the dashboard, you can filter to your age categories of interest. You can look at adjusted rates of a given condition adjusted for sex and age by race and ethnicity, and then also look at prevalence by sex. And again, this is cases of diagnosed dementia and folks who carry a diagnosis within the electronic health record. Similarly, we've developed a code set or algorithm to identify cognitive impairment with higher prevalence than dementia, of course, in the age category 60 and older. You can filter by a variety of other conditions here, and you can look year over year as well. And then on our special population prevalence page, you can look at these conditions by different populations. So this is comparing people recently enrolled in Medicaid to the general population. And you can compare, again, different categories by race, ethnicity, sex, and age between people who are enrolled in Medicaid versus other types of health insurance. And again, you can filter to your condition of interest or by different condition groups, whether that's like any mental health condition or both mental health and a physical health condition, so forth. We have compared our Minnesota Electronic Health Record Consortium estimates with modeled census tract estimates from CDC, primarily through their behavioral risk factor surveillance system surveys. And this chart shows in blue where our prevalence of disease is lower than what is reported by BRFIS, and in green, places where our estimates are higher. And you can see that there are some important differences in our estimates relative to the modeled estimates from BRFIS. We also have done a fair amount of work looking at trends in viral illness, and the initial project started with COVID, and so this is actually work that we've been doing the longest. We have a dashboard where you can quickly look at trends in a variety of viral conditions. When we first started this, we were doing all of this weekly, and as we added more projects, that weekly cadence became pretty challenging. So now we do this on a more of an as-needed basis for projects and when needed by the health department. We early on helped the state by using these methods to look at vaccine uptake by race, ethnicity, and other demographic characteristics. And on our public dashboard, we report on total number of tests, percent positivity, and then you're able to look at trends over time and by geography. Just a couple of quick slides on what this looks like here. This is data through November, and you can see, by just comparing these trends over time, you can see when the flu season really starts to tick up. That's much higher now. And then you can also compare season over season. So this season flu season starting maybe just a little bit sooner than other years as well. You can also break down vaccinations by a number of categories as well. So here we have COVID-19 vaccination rates for last season by age, and then within each age category, you can break down the vaccination rate by race and ethnicity. And just an easy, publicly available way to analyze what the vaccination trends are in the community. All right. And then finally, wanted to highlight some of the substance use related work that we have been doing in Minnesota, and that has really developed and matured over the last couple years. So we were initially funded through Hennepin County to provide the Metro Public Health departments with timely data to inform policy. As any of you who do substance use work know, often the data that is frequently used to inform policy decisions is mortality data in this space. That data is typically delayed at least a year, often two to 3 years. And so we're making decisions off of data that was 2 years ago, and these trends can change fairly rapidly. And so the idea here was to use healthcare data to provide a closer sensor to what was a more timely sensor to what was happening in the community. So for this project, we initially included sites that had at least one hospital in our 7-county metro area in the Minneapolis-St. Paul area, and have been expanding that over time so that within a few months, we will have essentially a statewide view of this work, but the data I'm showing you here is just for the metro area. We update this data quarterly right now. There's a dashboard that is hosted by Hennepin County Public Health with the data that we produce. And as we add on statewide sites, we'll also be producing a statewide dashboard that will be on our website. So here you can see these are trends in opioid-related emergency department visits, and you can see the trends by race and ethnicity over time, with a large percentage of emergency department visits among American Indian residents being related to opioids, and increasing rates of visits across a number of other racial and ethnic groups. We break down the data by year, by substance, and by demographic characteristics. And so this is a page that makes it really easy just to understand broad trends in emergency department visits related to substances, and look over time across all of these different categories. We are able to look at trends in substance-related emergency department visits by age. And you can see in this figure that there are 2 age categories that have steadily increased over time. Those in the 65 plus age category and in the 45 to 64 age category have continued to see steady increases in substance-related emergency department visits, while groups in these younger age categories have seen declines or at least stabilization in the last couple of years. We link the emergency department visit data with administrative data sets as well. Here you can see the percent of visits related to opioids by housing status. So a larger percentage of emergency department visits among people with recent homelessness are related to opioids compared to those with no recent homelessness. We also link to Department of Corrections data and Medicaid enrollment data as well. So those are a couple examples of the type of work that is possible in this distributed data model. We've highlighted a couple of the public-facing dashboards and some of the methodological analyses that we have underway. It has been a very active time in thinking about where we go from here with the model that we've developed in Minnesota. There are a couple of initiatives that I wanted to share with this group, and would love to take questions and get additional thoughts from this group as well. one thing that we are very interested in is testing the scalability of this model to other states. We have been partnering with Regenstrief in Indiana on testing some of the scripts for our Health Trends Across Communities project with the statewide OMOP database that is hosted at Regenstrief. I was just in touch with one of their analysts this morning who's planning on starting to test those R code scripts this week, and hopefully we'll be able to reproduce these statewide estimates in another state. We are also in conversations with additional health systems in the Dakotas and in Wisconsin, and hoping to expand this network regionally in the upper Midwest over the coming year. A newer area for us is in more active collaboration with one of the state certified health information exchanges in Minnesota to really think about how we create a comprehensive health data ecosystem. The HIE is able to send data in real time for clinical purposes, but it's not a system that all systems participate in to the same degree. There's a variety of electronic health information that doesn't pass through, and the way that it is stored in the HIE is often not conducive to research and evaluation. So we have been talking with the HIE about how do we connect smaller systems who do not have the capacity to build their own OMOP databases, but may be able to send a minimum set of data through the HIE, which could then be mapped centrally within an HIE to the OMOP Common Data Model as a way for both smaller systems to participate in research and evaluation studies, and as a way for sites that may not be on Epic or Care Everywhere to link into additional healthcare data that can be used in providing a more unified healthcare record. The other major conversation that we're having is around quality reporting. In Minnesota, this work to coalesce statewide quality metrics is run through an organization called Minnesota Community Measurement. And Minnesota Community Measurement does map some of the smaller system data to the OMOP Common Data Model, and that does allow smaller sites to participate in these projects. What we have heard from larger systems who have the OMOP Common Data Model is that they would prefer to run their quality reporting straight out of their OMOP databases. And so we are working with Minnesota Community Measurement to create queries that would limit the amount of information health systems need to send to the quality reporting agency, and use standardized scripts to pull that quality information directly out of the OMOP Common Data Model. And this would build off of the scripts that we generated initially for our Health Trends Across Communities project. So I think the main thing here is how do we both scale to expand the collaboration and to form partnerships across states, while also ensuring that we reduce duplication and try to strategically develop this system in a way that reduces reporting burdens for health systems and clinics. So in conclusion, the consortium has developed a statewide infrastructure for research and evaluation that has been resilient to multiple shocks in our state and across the country. And this is a model that is appearing to be scalable to other states. The consortium is a valuable source for age-related data, including dementia, cognitive impairment, and other chronic conditions. We have a dementia working group that consists of experts across the health system and public health agencies that defined the code sets for these conditions and that are working on other collaborations and use cases in this space. There is additional information available in the EHR beyond what we're already reporting on that could certainly be used to further expand our understanding of needs among older adults as well. So I think we have really just gotten started as a consortium in this space, though many of our members have been working in this space for a long time. And we're excited to really think about what other use cases might exist. So that is everything that I have, and this is my contact information if you have any questions. Hopefully our website's back up, but if not, save the bookmark. It should be back up once we get our server all switched over in the next 24 hours. So thank you all. Thank you, Joe and team, for having me, and I'm happy to take any questions that you all have.
This is great, Tyler. Thank you. The work here has such significant implications for Minnesota and beyond, so we really appreciate it. I think I'll use my host privilege to ask the first question, Tyler, for those of us in this space, which is this. Certainly the granularity that is possible with this type of EHR consortium is beyond, as you mentioned, what's available through public health data sets or other types of surveys and such. One of the challenges in dementia, I think they're twofold. One is the fact that even in the most progressive healthcare systems, dementia is woefully underdiagnosed, number one. And then number two, EHRs, when we're thinking of, for example, using these type of information as a way to guide or target services and supports, in the case of dementia, often a caregiver, a care partner, is pretty critical to those efforts. And EHRs, by and large, don't really identify care partners because healthcare systems aren't incentivized to do so. Nor their health needs, of course. And so, and I know Renee is on. Maybe Renee wants to talk a little bit about this through the bold work and everything in Minnesota. But those are two issues, and I'm wondering how the consortium and this work group is trying to address them.
Yeah, the issue of diagnosis versus prevalence is $1 million question. And I'm sure there's folks on this call and in the consortium who know a lot more about this than I do. So I guess I'm going to duck a little bit and not totally answer your question.
That's a good answer.
But to say that, there's still a real value in survey data. This does not just replace, the need for doing surveys. But what we have found in working with local public health agencies is, a good deal of their public health surveys are like, have you ever been diagnosed with diabetes? Have you ever been diagnosed with blah, blah, blah? And what we're finding is that what we're producing is, in many cases, able to replace some of those basic questions. And that means that the surveys can be more targeted. And so without sort of greatly expanding the length that someone's needing to engage in the survey. So I think with our ability to offload the need for many questions that are in local public health surveys, you may be able to spend more time on really getting at some of the conditions that are harder to really estimate prevalence in from the electronic health record. The second thing I would say is EHR data. It when we think about prevalence, it may not be able to exactly answer how many people have dementia, but it can answer the question of what is the burden on the healthcare system. And that is a different question, but a very important question. And even answering that question of like, what is the burden on the healthcare system and what does the healthcare system need to be prepared for, can help in that type of planning. There's, in terms of this family linkage, it is across this family linkage piece across the age span is a really important issue. We have been talking with a variety of centers across the country on how do you create family linkages within the electronic health record. And we are hoping to engage some of these centers in the next year to start to pilot some of this work within the consortium. So certainly if there are folks interested in this, we would love to partner and engage. But I do think that developing, refining, implementing these family linkages are important, Joe, for the questions and the issues that you raised. But these are factors that are really important at a variety of stages across the lifespan.
Yeah, I mean, this could be a whole other conversation of itself, but I know we have other really interesting questions in the audience. And Katie, it sounds like Cindy. It sounds like you were moderating some of the questions. Do you want to direct people to ask them, or can you ask them for them to Dr. Winkelman?
Yes, Cindy, we'd love you to ask your questions. I think everybody will be interested.
Thank you.
Yes.
Thank you for this presentation. This is. See, am I unmuted?
Yes.
Okay, you can hear me now. Okay. I'm Cindy Carlson, Director of Wisconsin Alzheimer's Institute next door, and I'm really interested in the STARS program that Joe and others have led, and this work that you're doing. We've been trying to work with our School of Medicine and Public Health on some systems that, again, you've done fabulous work here. So I'm just curious if you could just touch base on, and I think you mentioned this at the beginning, but some of how you started funding this initiative, if it was smaller scale, like some of the substance use, smaller programs, and then leading to this larger consortium, or if you had state funding, county-based funding, like if you could talk a little bit about that, was one of my questions.
Yeah, it's a great question. We initially started during COVID without any funding, just thinking that it would be a good idea. And so we did take advantage of the early days of COVID where everyone was trying to just figure out what they could contribute. And we had a group of, willing and able analysts and PIs to jumpstart this. Then that lasted, 3-4 months or so. And then we were able to start funding some of the project through the state health department using COVID dollars. We then got some infrastructure funding from the state to build out the common data model at each of the sites. And since then, it has been a combination of CDC, NIH, state and county funding that we have pieced together over time. We have also recently been having a variety of conversations with local and national foundations, many of whom are interested in data efforts. And then we'll kind of see what is of interest to the state and whether sort of there are projects that could support the rural health transformation program that all states have received funding for this year. So I would say, yeah, no magical points around funding other than we've had some really wonderful partners both in county and state government and motivated investigators who've been applying for NIH funding and folks willing to have lots of meetings with foundations. So one of the nice things about the federated model is that it engages a whole host of people and it expands the conversations you're able to have with potential funders and the number of applications you're able to submit.
That's great. Thank you. Am I allowed to ask my second question? If that's okay, Katie?
Yes, please do. I think you're not the only one with
Okay.
that question, so that'd be great.
So that was really helpful. It makes sense that it's going to take a village of partners to make this work. My second question was, one thing we're interested in is looking at provider or clinic level healthcare patterns. And are you able to do that, or do the healthcare systems want to keep that within their own healthcare systems? So for example, you have such nice public health data on like hypertension rates. Can you see how well hypertension is identified within those healthcare systems, how well it's addressed, as a risk factor for dementia, for example? So I'm just curious how well you're able to look at that provider and clinic specific data, or if the healthcare systems really want to keep that under their own wrap.
Yeah, I mean, it's certainly possible from a technical aspect. The way that we've structured the DUA is that for any, in order to report at the system or clinic level, it would require a use case where that was needed and the consent of a participating system. So we haven't had projects yet where there was a compelling use case to do that. But if that was of interest, we would certainly talk with sites, and then sites that were interested in sort of that level of identification could sign on. For the quality reporting that we're doing, that will be at the clinic and health system level. And so the technical capacity to do that kind of work is there. It just requires a consent and use case for the systems. We do internally, for QA purposes, look across systems, and that's mostly to make sure, if diabetes prevalence in most of the systems is whatever 30%, then if there's one site where it's 80%, that helps us identify places where we might want to do some QA.
Thank you.
Looks like we have another probably our final question today. I wish we could keep going. There's so much to talk about here. So we have an anonymous attendee who shares, "What an incredible project. Thank you for your presentation. What were barriers that you encountered when inviting health systems to participate, and how did you overcome these? I'm curious about how to explain how the benefits outweigh the burden for engaging in this type of project."
Yeah, it's a fantastic question. And I would say for the bigger systems, the biggest barrier was, I think, just building those personal relationships and sort of figuring out who's the right person to work with. But once we did that, and we created a community, that has been, it sounds sort of quaint, I guess, but having this community that is engaging and meaningful has been hugely binding. And for example, we've been meeting at 8 a.m. on Fridays since 2020. And we have about 60 people that attend every Friday morning at 8 a.m. And I think that says something about sort of the ethos of the group, that you have 60 people who kind of show up every Friday morning at 8 a.m. To talk about events. The other thing I'd say is, we pay people for their time. So we make sure that if we're going to engage a site, that we can cover their costs. And so we're not asking sites to donate their time or build anything that's not covered. So I think in a lot of these data spaces, it can sound like, oh yeah, you just map over a few variables, like go ahead, but that's real time. And health systems are typically at max capacity in their IT and analytics shops, and they don't have excess. And so to engage folks, you really need to be able to cover the FTE. But once you do that, you can get really great buy-in, because it's a meaningful community. Analysts, PIs learn from each other. And I would also say, really, the governance board has been strategic in trying to focus on projects where the likelihood of informing policy and practice is high. And I think when folks are engaged in a community where they feel like they're really having an impact, that helps folks stay at the table.
Thank you, Dr. Winkelman. Again, I think a tremendous presentation, has significant implications for our work at the STARS Center. I think many of the other dementia-focused initiatives that are going on, both at MDH, you heard from Dr. Carlson and the Wisconsin Alzheimer's Institute. So we really appreciate this. I have no doubt that we likely will be following up with you, as will others. Everyone, if you do have additional questions for Dr. Winkelman or any other thoughts, please make sure to complete the survey we're sending out to you, and then visit us at starcenter.org or email us at starcenter@umn.edu. Thank you, Tyler. Thank you all for attending this wonderful presentation, and I hope everyone has a great rest.
Take care.